Hello, my name is Dr. Rajiv and welcome to my education channel Surgery and Orthopedic Education. Today I have a general surgery lesson for you, that is early recovery after surgery, ERAS or fast track surgery. Please subscribe to our channel if you have not subscribed it yet, and don't forget to give us a like at the end if you find the video useful. So let's not waste time anymore and start right now. The enhanced recovery after surgery (ERAS) is a model of perioperative patient care. It was introduced in 1997 by a group of general surgeons from Northern Europe led by Henrik Kehlet. Research has consistently demonstrated that the adoption of a well-planned enhanced recovery or ER protocol leads to significant improvements in patient satisfaction, patient outcomes, and reduction in the duration of hospital stay and cost of care. Importantly, to successfully adopt ERAS protocol into clinical practice, a structured, collaborative, and multidisciplinary approach is needed. Traditional perioperative care has changed after our new understanding of the metabolic response to surgical injury and the mediators involved. Now, there is a strong scientific basis for avoiding unregulated exposure to stress, prolonged fasting, and excessive administration of intravenous fluids. The key elements of ERAS are patient and family education, preoperatively, patient optimization prior to admission, minimal fasting, carbohydrate beverage 2 hours before anesthesia, multimodal analgesia with appropriate use of opioids, return to normal diet and activities on the day of surgery, and returning home early. The worldwide adoption of minimal access surgery, such as laparoscopic surgery, is a big change in surgical practice. This has reduced the magnitude of surgical trauma and enhanced the rate of patients' early return to homeostasis and recovery. Overall, ERAS protocols do produce improvements in patient outcomes, especially in the reduction of hospital stay. But on the downside, the complications and readmission rates have been significantly reduced only for colorectal surgeries. The worldwide adoption of minimal access surgery, such as laparoscopic surgery, is a big change in surgical practice. This reduces the magnitude of surgical trauma and enhances the rate of patients' early return to homeostasis and recovery. Major surgery induces inflammation and metabolic stress, which may be exacerbated by pre and post-operative starvation, leading to post-operative insulin resistance caused by endoplasmic reticulum stress-mediated glucose transporter protein type 4 or GLUT4 downregulation in skeletal muscles. Modulating the stress and inflammatory responses during surgery may have long-term implications during the post-operative period for months. For example, beta blockers and statins improve long-term survival after major surgery. These effects occur due to the suppression of innate immunity at the time of surgery. Early post-operative insulin resistance has several similarities with the insulin resistance found in type 2 diabetes mellitus. Insulin prevents the development of ketosis and protein breakdown. During the perioperative period, adequate insulin must be present to prevent metabolic decompensation. The use of epidural analgesia reduces pain, blocks the cortisol stress response, and attenuates post-operative insulin resistance by preserving the body's protein economy. It favorably affects many of the patient-centered outcomes important for post-operative metabolic and functional recovery. It is noteworthy that due to the reduction in wound size and tissue trauma, the epidural analgesia is no longer recommended after laparoscopic surgery for pain reduction. Patient-controlled analgesia is usually effective. Adjuncts such as spinal diamorphine and or infusion of intravenous lidocaine have been shown to have opioid-sparing effects to improve gut function and enhance overall recovery. IV lidocaine is a potent anti-inflammatory, anti-hyperalgesic, and gastrointestinal pro-peristaltic drug. There are many kinds of stress responses of our body to surgical stimuli. These are less pronounced during minor procedures in normal healthy individuals, but they can be significant for patients who suffer from multiple comorbidities such as cardiac disease, hypertension, diabetes, etc. The surgical stress responses are different in the pre, peri, and post-operative periods. They are influenced by factors such as hypoxemia, sepsis, dehydration, hypercarbia, hypothermia, tissue edema, tissue ischemia, immobility, starvation, hypovolemia, hypercarbia, pain, and sympathetic stimuli. General anesthesia does not abolish such responses completely, although can reduce many of them. Regional anesthesia in the form of nerve blocks or epidural or intrathecal blocks abolishes such responses to a much greater extent. Maintaining adequate hydration, using anxiolytics, glucose, insulin, lidocaine infusion, and beta blockers, and avoiding laryngoscopy, intubation, big incisions, tubes and drains are all known to prevent and abolish traumatic stress responses. Adequate analgesia via epidural opioids and local anesthetics reduce catecholamine release. Early recovery from surgery is a new norm to prevent post-operative complications.